Hey, my name is Chris. Thanks for tuning in again. Today I'm going to be talking about lupus and pregnancy. So the main focus of the video is going to be pretty much the risk of flares prior to pregnancy, how to optimize yourself in the preconception phase as well, and then generally the risks associated with lupus in pregnancy for baby and for yourself. And then generally medications that are acceptable, primarily hydroxychloroquine, as well as management styles in the postpartum period. Today we're going to learn about lupus and pregnancy. So starting off the video, these are the four main topic areas in lupus that I'm going to be discussing. So jumping into the definition, so in the 13th century, Rogerius was the first person to coin the phrase lupus, likening the rash on the face to what a wolf bite looks like. This is now defined as a malar rash. Malar is Latin for cheekbone. That's how we get that name. And then in 2019, EULAR guidelines, kind of briefly going over it. I'm not a rheumatologist, but generally, most patients with lupus, 95% have ANA positive. This is very sensitive, but not specific for lupus. To be more specific, you need double-strand DNA or anti-Smith. And there's some clinical presentations I listed down below: fever, low white count, you have mucocutaneous lesions, joint pains, and renal issues as well. The antibodies are listed down below, and the antiphospholipid antibodies, for people who don't know, are going to be your beta-2 glycoprotein, cardiolipin, as well as lupus anticoagulant. This is a slide off of UpToDate showing the weight that each criteria can provide, and if they get greater than a score of 10, then that is the diagnosis of lupus in the setting of patients who have positive ANA titers. So jumping into preconception counseling, so chatting with your patients, you can definitely tell them right now that roughly it affects 1 in every 1,200 births. This was off of the 2008 paper. And then for like most autoimmune diseases, there's this 1/3, 1/3, 1/3, where a third improve, a third remain unchanged, and a third worsen. So unclear on which category they have, but if they have renal disease or if they have active disease during pregnancy or in the preconception phase, then that might push them over into the worsen category. And then for active disease, as I was saying, there's an increased risk for pregnancy loss 3 times the average. And then for spontaneous abortion for well-controlled lupus is roughly 4%, even if it's well-controlled. And then overall, there's a 7% risk of major morbidity. And those major morbidities pretty much are pregnancy loss, preterm birth, fetal growth restriction, and cesarean section. Antihypertensive use is increased by 8%, times 8 relative risk. This can be reduced a little bit if you have 4 to 6 months of quiescence prior to conception. Quiescence means just like you don't have any disease. And this is very similar for like if you look at like Crohn's disease or ulcerative colitis, they still go over this 6-month quiescent period, hopefully allowing for resolution of any inflammation. For antihypertensive, this is important because if patients have pre-existing condition of high blood pressure, this disposes them to like a higher risk of having high blood pressure or worsening blood pressures within pregnancy. And then lastly, 15% of patients with lupus are going to have APS, which is the antiphospholipid syndrome, and that's important because they need anticoagulation for them. So checking those antibodies is going to be very important for those patients. And then you have primary pregnancy outcomes. So you have the 1/3 that might improve is if they only had confined or cutaneous rash. So if they had only the malar rash, then that's probably a little bit better, where if they have, lupus nephritis, nephrotic or nephritic syndrome, then you might have some more complications, and if you watch them closely a little bit better. The specific lab tests are going to be anti-Ro, anti-Law, and I'm going to be going over that a lot more. And you have renal and liver dysfunction. So if you're looking at renal levels, so if their UA is positive for protein, you reassess with serum creatinine, and that's bumped up, then it's probably best to get that optimized first prior to jumping into having a baby. Because if they have elevated creatinine levels, then that is also an increased risk factor for a lot of those things that I was talking about on the earlier slide, where preterm birth and stuff in regards to lupus. You can also have other autoimmune diseases. One of the most common ones would be Hashimoto's. The way you can check for this, I have free T4 and TSH. The first test you're going to be doing is a TSH though. So it is reasonable to check this because they possibly and might likely have other autoimmune diseases that might need medical management. So now we have that. We're going to jump off into antepartum care. So I've broken this up into two main sections. We have maternal and fetal well-being. So the fetal well-being, the two main things are fetal growth restriction. You just have to know that there's like a 1.7 relative risk increase in those babies if mom has lupus, as well as oligohydramnia. So monitoring fluid levels in those babies are going to be super important. And now primarily focusing on maternal well-being, and this is where a lot of the talk is going to be. So there's thrombocytopenia risk. So, if you have low platelets, the way you're going to check for this is, you're going to get your preconception CBC and assess them throughout. And this is important because if they have low platelets, you're going to be pretty cautious because you have to watch out for HELP syndrome, mimic, and you're also going to have to make sure that they're able to be optimized if they would like an epidural prior to their pregnancy. The next thing also is proteinuria. So you have lupus nephritis, as I said before, and even if they don't have a diagnosis of this prior to pregnancy, this can actually form de novo. So it's important to get your UA and your creatinine in order to assess if there's worsening changes. The way lupus nephritis is formed, there's just immune deposits that go into the glomerular structure, and then that causes inflammation, and then you get lupus nephritis. You can either have protein or no protein in the urine, but it's still important to kind of assess for this. And the last thing is screening SSA and SSB. This is anti-Ro and anti-Law. Anti-Ro, just as aside, was actually named after one of the first patients from a rheumatologist. They named it after one of their patients, and they just named Law just because Ro was similar to it. And that's like the main section for that. So now going back to SSA and SSB and why it's so important to screen. There's two main syndromes that are at increased risk if patients have anti-Ro and anti-Law antibodies. And the first one is neonatal lupus syndrome. And although I'm not a pediatrician, the increased risk primarily is at 4 to 6 weeks of life in babies. They're going to have usually skin lesions. Roughly 30% we're going to have them. And then I have a picture right there on the slide to kind of represent what that might look like. The more concerning thing, though, is this congenital complete heart block, CHB, also commonly referred to as in the literature. And on the right, I have like the electrical system within the heart. And what happens is there's diffuse myocardial fibrosis from the anti-Ro, anti-Law that mom has, travels through placenta and then affects baby's heart. It primarily hits, this area right here. You're going to have your AV node all the way down to Purkinje and bundle of His and up to Purkinje's. So that's where it's going to be hitting it, and that's how you're going to get your complete heart block. And the question really is how are you going to be able to benefit this? So 2% general risk if you have anti-Ro or anti-Law antibodies. And if you have anti-Ro for sure, then you have an increased risk of 7.5% of having complete heart block. You're going to want to start your fetal echoes at 16 weeks. You're going to want to do this every 2 weeks afterwards just to assess if there is heart block. And if you actually had a prior pregnancy where they did have, CHB, the risk of having CHB again is roughly around 1 in 5. So you have to be really careful with these patients. But how are you going to treat this? And then I have all these options right here, and then none of them actually are the preferred or the most proven way to manage this, which is really complicating about this because it's a really bad diagnosis. Some of the ones I have listed on the screen are fluoridated steroids, and this is important because it won't get broken down by the placenta. These are beneficial for first-degree heart block as well as high drops in babies. Not necessarily been shown to be proven to be beneficial in patients who have CHB. And the reason why steroids actually is beneficial, though, or the theory behind it is and that's why 1/3 of pregnancies actually improve with autoimmune diseases, because pregnancies increase corticosteroid levels. So this might be able to reduce the inflammation risk, and that's how this is theorized to work. You got your beta-2 agonists. Primarily, this is pretty much common one on our floor. We have terbutaline, right? Terbutaline is beneficial for patients because, if they have a low bradycardic event, 55s, 40s, you can actually speed up the heart rate, which is, one of the side effects we have to tell our patients about. And this will help, perfusion abilities for the baby to get the heart beating more. You have plasmapheresis. This is going to, shave off all the antibodies that are in mom's blood, and this is going to help reduce the amount or the concentration that gets, transplacentally provided to baby. Then you have IVIG. IVIG is just, immunoglobulins that will bind to the FC domain of the antibodies, anti-Ro, anti-LAW, and it kind of just, will sequester them so they won't be able to be transferred across the placenta. And then lastly, you have hydroxychloroquine. This is HCQ. HCQ is beneficial for these patients. Also, it's an anti-malarial drug. It also is more of an immunosuppressive. It hits the TLR pathway, so it actually reduces inflammation, and that's the theorized effect of hydroxychloroquine. And I think most of the research I've done is kind of really seeing that HCQ is actually pretty beneficial for patients in general for lupus, as well as theorized beneficial effects for CHB prevention. Management of meds. I know that was a lot, but right now there's two main ones. You got baby aspirin. You want to try this at 12 weeks of gestation because there is an increased risk for preeclampsia in these patients, and aspirin has been shown to be beneficial. This is, the 21 milligram dose, and you want to reduce your pre-E risk in these patients. And of course, if they've already had hypertension prior to pregnancy, then you're going to have an increased risk, especially with lupus. So it's important to make sure you're monitoring that for your patients. And then you have Plaquenil. This is hydroxychloroquine, HCQ. All those names are similar. The dosaging that we're looking at is greater than 200 milligrams per day, or 5 mg per kg, has been shown to be beneficial. Higher dosages have been shown to be more effective. The concern is that we don't put all these patients on Plaquenil because there's an increased risk for a certain type of disease. And that disease is vision-threatened toxic retinopathy. So there's an effect in the eye. I wasn't able to find literature in the research that showed that during pregnancy this was associated with it, but in general it is a known complication and side effect of the medication, so that's important to talk to your rheumatologist about. And then there's the reduced CCHB risk from 21.2 to 7.5%, and that's how I got the 7.5% quoted when you had the comparison for the CCHB in the prior pregnancy with anti-Ro. All those moms were taking hydroxychloroquine. And then you got your flares. So, this is one of the pretty bad things. So if you have lupus and you got a flare, preconception, you shouldn't be getting pregnant if you had a flare within the first 4 to 6 months prior to pregnancy. But if you had a flare during pregnancy, it kind of sucks. You increase risk, is like if you had lupus nephritis, and those patients are more likely to get flares. The way you're going to manage those patients is really assess, have they been taking their medications? And if they have, that's good. If not, counseling is important. And then you have to look at, do they have a diagnosis of lupus nephritis prior to pregnancy? Or do they have a new one of a de novo generation of it? Or is it a non-renal flare? Because if it was a renal-associated flare, then methylpred 100 milligram Q3 day is going to be beneficial for those patients, and non-renal flare is the one listed below as well as an IM version. And last but not least, we got postpartum management. So generally, there's an increased risk of flares in the postpartum period. Hydroxychloroquine can reduce flares within 12 weeks of postpartum. I wasn't able to find more literature that expanded past those 3 months. It is safe with breastfeeding, so knock yourself out if you want to breastfeed and you're on Plaquenil. It is safe for you. It's safe for baby. And the labs you're going to want to follow up are, a urinalysis, a urine protein creatinine, and a complete blood count, CBC. The UA, if it comes back positive, you're going to want to reflex that back for a serum creatinine because maybe they formed lupus nephritis, and that's what you're going to want to look out for. And if there's severe disease, you're going to want to look at the double-strand DNA titer levels as well as complement and see if the complement dropped. And then, as I was saying, high blood pressure is a very huge risk for patients with lupus. So doing frequent blood pressure checks, 72 hours after you get discharged, as well as maybe, BID blood pressure checks at home with follow-up at, primary care, OB, or rheumatologist will make sure that you're not missing any hypertensive disorders in the postpartum period. That being said, that's pretty much all I got on lupus so far. I will link all of the descriptions for those papers that I referred to for all of my research in the comment section below. I hope you learned something, and see you next time.